Thank you, Professor Yako, for that, for highlighting the challenges with vaccine uptake in Kenya and indicating that it's not just related to accessibility, but also to acceptability. So now the floor is open for your questions and for discussion. Panel members, please can you turn on your videos? So please raise your virtual hand to ask your question. So while we're waiting for hands to raise, I'll ask the first question, and this is around, this is posed at Victor, and so Victor, you talked about the refugee status in Zambia, and I was just wondering about what the status of vaccination and uptake is in Zambia currently, and how do you figure in the refugees into this vaccination rollout plan? Do refugees have access to vaccines?
Thanks for that question. Yeah, so in Zambia, we got the first consignment of vaccines in April this year, and that was limited to just about 250,000 doses. And initially, in fact, this was meant only for frontline workers, and that included healthcare workers, immigration officers, revenue officers at the point of entry into the country. And so it was quite a limited consignment. And of course, it brought issues because there were a number of discussions on how this decision was made and whether fortunate or unfortunate. We see a situation where, because of vaccine hesitance that people have talked about, this was finally opened up to the public, but that did not include the refugees. We got the next consignment later on in July, and that was now bigger enough, pushed the total number to about 920,000 doses. Again, it was limited in terms of access, and that was distributed in most of the provincial facilities up to some districts, but it did not trickle down to the refugees. And so we still have a gap there.
Thank you for that response, Victor. And so I think that is a challenge, and as the Director General of the UN has stated that, you know, we are only as strong as our weakest health system. So that is a real challenge. So I see Professor Moodley has a hand up, and please go ahead and ask your question.
Thank you, Lulu, and thank you to the panel for such an excellent session. I think it was really great to have perspectives from Kenya and Zambia, and to look at, you know, the philosophical arguments that Stuart built up right at the beginning around vaccine certificates. And thank you, Stuart, for distinguishing between vaccine passports, you know, that seem to be associated only with travel, and the vaccine certificates that are going to be used domestically. So South Africa has a very different scenario to many other countries in Africa, in that we have a very good supply of vaccines at the moment. And consequently, the government has developed a digital vaccine certificate, and there are plans about restricting access to certain venues based on the use of these digital vaccine certificates. So, Stuart, if you were in South Africa and under these circumstances, what would you feel about the use of digital vaccine certificates in our country? You need to unmute, Stuart.
Yeah. When you say that there's, increased access to vaccines, what does that look like? Is that like 50% or fully vaccinated? Depending on the criteria for getting the certificate. Is it half the country or less at the moment?
Stuart, so there's vaccine supply available to anyone who wants a vaccine. Anybody 18 years and older may access a vaccine in South Africa. We have J&J and Pfizer available, J&J in a single dose and Pfizer in 2 doses. Currently, we've vaccinated more than 15 million people, and of that, about half are fully vaccinated.
Yeah, I don't think, the higher the vaccination rate is, the less problematic a certificate is that's based on vaccination. Obviously, you want, if people are excluded from that, ideally the best exclusion would be exclusion by choice. Some people, they decide they don't want to get vaccinated and knowingly, and they are excluded from having such certificates. I think that taps down a lot of the fairness issues when it comes to these certificates, but that takes a while to iron out. And not everybody agrees with that either. They think that their choice, they shouldn't be so-called punished for their choice. That's like an apart argument. But I think that when there's real access, I mean, not just that they're available, but also the barriers for people, including transport and other possible barriers which make access, available in principle, but not really in practice. As long as those are ironed out too, so that the people really do access the vaccines who want them, then it becomes much less problematic. If you don't have all of that, you do end up with the internal problem of usually a social economic elite being the ones who have these licenses, and so you've got internal inequity. But it sounds like South Africa is on a path towards a certificate program which may be ethically defensible.
Thanks, Stuart.
Oh, Lulu's muted now.
Lulu, muted.
Sorry about that. I think there was a question from Margot to go first, and then Professor Jaco. Okay, Professor Jaco, can you go ahead with your question?
Yeah, so it's just some consideration with regard to the COVID passports when it comes to international travel. More recently, there's an issue of which vaccine will be acceptable and which will not. The Europeans recently had issues with the COVID vaccine that is manufactured in India, yet it is the same AstraZeneca vaccine. And that would even be lighter. Now there are countries like Cuba that are vaccinating, they've developed their vaccine. Iran has some vaccines. So what I see with this COVID passport also is a great divide between the West and the resource limited countries, because there is no way, in my mind, the West will allow people vaccinated with an Iranian vaccine or a Cuban vaccine access to their country. So that will create another ethical issue as well. Thank you.
Okay, thank you for that point, Professor Jaco. I think there's a question from Professor Margot.
Okay, thank you.
Professor Margot, we can't hear you. Okay, Professor Margot, please go ahead.
Okay. Can you hear me now?
We can hear you now.
Can you hear me now?
We can. Go ahead, please.
Okay. I was saying I want to agree with Stuart with regards to high inequality that has been created by the pandemic, because in addition to these the licenses or the passport that he was referring to, we also have, you know, PCR tests, the COVID tests that are mandatory, and they are highly priced. And you find that those who cannot afford will not be able to travel. They don't have those liberties to travel. And there is high exclusion as a result of that. So it's a problem upon another problem. And the question is, in terms of people being forced to be tested, some are asking, why should I be tested, yet I received a vaccine, which means I'm no longer susceptible to the COVID-19 because I'm protected somehow. So why would I be bothered to pay large amounts of money to, you know, to get tested, because it's highly priced? And I think capitalists are also enjoying as a result of that. Thank you.
Thank you, Professor Margot, for that, for your input. And it's both you and Professor Jaco bring up the issue of vaccinations creating a bigger divide between developed countries and developing countries. And Stuart did mention during his talk, he talked about vaccination passports for external traveling out of your country, and also for vaccination passports within your country. And then Stuart, I see your hand up, but could you please comment on what you think would have the bigger impact, whether it's that for external travel or for internal use?
I think in the short term, also for reasons that Walter raised, it's probably going to be the approaches that are going to be the most ethically defensible are going to be internal and domestic, and maybe even provincial. Like, I'm speaking from a Canadian perspective, where the provinces have some autonomy, and certain provinces are each have their own vaccine certificate programs, either in place like Quebec, or on the way, like provinces like Ontario. I think those also given this is a context where there's high vaccine access. I think in the short term, those have a chance to be ethically defensible. Of course, some people will argue against them for the usual anti-vaccination or anti-government reasons, but those have the best, the best chance from an ethical perspective to be justifiable. Internationally, that's going to be much harder, because for reasons that Walter gives and others, depending on what the criteria are for those kinds of vaccine passports, that's going to create inequities, definitely in the short term. And I don't think we're anywhere near a place where international vaccine passports will do anything but entrench the inequities that are already there.
Thank you, Stuart. I see Professor Minri has her hand up. Please go ahead.
Afternoon to the panel. I want to ask two questions as well that I've been wondering about all this. What would the duration of such a passport be or certificate? What would this duration be? Because you hear the debates about another vaccination for the high income countries on 6 months or 10 months, and yet others are lacking behind. That's the one question. And the other is the whole debate about the variations of the vaccines protecting various variants of the virus, like the beta and the delta and whatever. That's why it threw South Africa back initially of what we had as vaccines wasn't going to work anymore. So just those two questions. Thanks.
Stuart, do you want to go ahead and address those questions? And then Victor and Walter, please feel free to chime in.
Yeah, I wish I had an answer to those questions because nobody seems to really know about duration, and it is important to have some evidence base for, you know, these kind of vaccine passports to say, well, they're good for this amount of time and you're covered. We have that with other vaccine passports and certificates. We have an idea, you know, of how long certain vaccinations provide coverage. That we don't have, and so that's a real problem moving forward. All we can do, we're in a situation clearly of uncertainty, and the only way that can really be cleared up is more research and try to find out how long the duration of the vaccines that we have provide a certain amount of protection, and even there, decisions have to be made as to how much protection is enough protection. So yeah, that will be complicated. And as for the variants, yeah, some vaccine passports could be rendered completely useless by variants that are not covered by the vaccines that the passports are attached to. Yeah, so these are real problems in the short term until you know, as long as there aren't that many mutations and we get more information about duration. Those are the elements that would make these passports, as we're doing them now, viable. But it's a very fragile situation that we're in at the moment.
Thank you, Stuart. And I guess that does address the question posed by Professor Mago in terms of, you know, travelers, international travelers being requested to have COVID tests done in addition to having being vaccinated, related to the uncertainty around the duration of immunity, whether it's natural or through a vaccine. So Victor and Walter, do you have any, would you like to provide any input around this question of vaccine passports?
Yes, so just like as the way Rene has said, we really don't know. It's a novel disease, so there are a lot of uncertainties and unknowns. The evidence currently, though, is that the vaccines seem to work across different mutants, and the most difficult mutant then is the B variant, the South African variant. But over and above that, most vaccines are working across the variants. So we hope that situation will be maintained, and therefore there'll be no need to give third or fourth vaccinations. But these things changes so much every day. So even just tomorrow, there might be some new information that makes it mandatory for people to get third doses for the vaccines that are being given in 2 doses. And even for the J&J, it might just be necessary to give a second, depending on the information. And then the big story of mixing, would it be even better when you mix the vaccine so that you start with the J&J and get an AstraZeneca or a Pfizer later on? And when if mixing is the route, so what do you do with the passports across borders? So if you have received what we call homologous vaccine, would you be denied to travel just because giving heterologous vaccine where you mix is better? So it opens up a very big kind of yeah. Thanks.
Thank you. Yeah, it's definitely a rapidly evolving or changing ball game, and how do we keep up with that? So I see Professor Wayne Towers as a question. Please go ahead and ask your question, Wayne.
Thanks so much, Dr. Ney. I appreciate it. Just to say to the presenters, thank you so much. This has really been an interesting discussion, both from sort of a theoretical perspective and the actual practical in the field perspective as well, which is always makes for interesting discussion. My question is maybe trying to tip over the apple cart a bit here, and maybe it's unfair to be asking this group of panelists, but taking into account sort of the experiences that we've seen happening, you know, where there's these big drives where doctors set up these huge drives to sign permission not to wear masks, and getting fake sort of COVID-19 vaccine cards and things like that. What are the alternatives to the use of vaccine certificates that are being worked on currently? You know, how are we looking at things like vaccine hesitancy and getting buy-in from the general public? I don't know if you maybe want to comment on that, because I think sometimes we look at one solution and it feels like there isn't a focus on the other solutions as well, if you would be willing.
Thank you for that question, Wayne. It's a really important one. And I think since Walter did mention in his presentation about hesitancy amongst civil servants in Kenya, whether you would like to take that question, Walter?
Yeah, the issue of vaccine hesitancy is it's a major one that is really affecting uptake in Africa. But as Renee has said, the problem with Africa, you cannot be very sure whether the low uptake is because we just don't have enough vaccines, or it is because people are hesitant to get the vaccination. Now in Kenya, it is estimated about 25% of people are hesitant to get the vaccination. And what is surprising is that includes healthcare workers, especially nurses. But when you do a survey as to the reason why they're hesitant to get the vaccine, the majority of that is because of the misinformation they get from social media. Now, what I find interesting myself is that a lot of the social media misinformation that is making people reluctant to get the vaccine is actually manufactured from the West with a very high vaccination rate. So the manufacturer of the misinformation is the place where there's a very high vaccination rate. And so the consumers of the misinformation is largely resource limited countries, and largely because for many, the only source of information or the major source of information is social media. They have no way of verifying whatever they get in social media, and therefore they take the misinformation. Now, linking up with the question, I'm not clear as to how that will link to vaccine passports or certificates for traveling. Would we say, are you asking the question if people are hesitant to get the vaccination, then it is justifiable for them not to be allowed access to facilities where people who are vaccinated are being given access to. I wasn't very clear, but the issue of vaccine hesitation is big. It can be a whole hour of discussion. Thank you.
Thank you for that response. And Wayne, do you want to clarify? I think Walter needed a bit of clarification around your question.
Sure, no problem. I don't know if my view is incorrect, but I feel sometimes that the implementation of vaccine certificates or vaccine passports is sort of a tool that's being used to increase uptake of the vaccine, to sort of force people to take the, and I'm just wondering, is there as much effort being put into alternative strategies, looking at the root causes of vaccine hesitancy and trying to address that? I'm not saying, I just wonder if it's not better to have sort of a multimodal approach rather than focusing on a what I view as more a stick approach than the carrot. And I feel we already have such difficulty getting people to take up the charge of getting vaccinated, and I feel that using a stick approach is probably not the right way to go about it. So that's the root of my question, basically.
Thanks, Wayne, for making this so much clearer. And would any of the panelists like to tackle this question before we move on to questions from Richard and Vincent? Walter, you're on mute.
Now I understand the question. I think for the Kenyan situation, it is not. There's no proposal at all for using vaccination certificates as a way of making people get vaccinated or to address the issue of hesitancy. So probably countries where that might be a possibility would be better placed to address it. But we don't have that problem in Kenya. Kenya, we don't even discuss the issues of vaccine certificates for anything, for going to the movies or going to supermarkets or even for traveling locally. Thank you.
Thank you, Walter. Stuart, your hand is still up. Do you have a response to this question?
I'll just say something quick, and then I have a question actually for Victor about vaccine hesitancy, just to give a perspective from the United States. I think that there was a lot of talk earlier on about, getting to the roots of vaccine hesitancy and so on, and sort of soft encouragement. And, I think they shot a lot of carrots around for a while. And then we lost patience. to tell you the truth, and now it's getting much more like sticks in terms of there's a lot of companies, a lot of universities that are bringing in mandatory vaccinations like they've had enough. They've already had a year and a half of trying to convince people of trying to get vaccinated, and now the gloves are off, basically. And it seems to be that there's at least two major things that are actually they are increasing. Though what Wayne said, I take it, in spirit too, is that it may not be the best way, but there are two ways that the unvaccinated are getting more vaccinated these days in the United States. One is mandatory vaccination policies in various parts of society, and the other is death. Basically, the fear of death, and watching people on CNN dying who were denying that there was a COVID-19 and vaccines don't work and things like that. So the death rate and the vaccination rate, there seems to be an interesting correlation, especially in the southern United States. For Victor, I had a question about, he talked about, coping strategies in Zambia in very difficult circumstances. I took it, and I was wondering if there in healthcare circumstances you were dealing with questions of triage and rationing, because that was talked about a lot in the United States. Everybody was like making their own, triage of ICUs and all these things, what would happen in those circumstances, and generally speaking, never used them because it never got to that point. But how did people make decisions like that when there was really scarcity of resources, like for ICU or oxygen? How did these coping strategies, as you called them, how did that look? I think you're on mute.
Okay, thank you. So it was and still is challenging. The number of healthcare workers at the facility providing healthcare services is already limited, and equally that is compounded with issues of infrastructure and also transport. And so, yeah, they have to utilize what is available, and so a lot has to do with just an extra tent or makeshift tent to just provide space for quarantine or isolation. But in terms of if the worst get to the worst and they have to refer a case that needs emergency treatment, or a severe case that needs oxygen, then they have to transport to the nearby district hospital. And again, that's where the challenge of transport was coming. There was no proportionate support in terms of having extra ambulance for that purpose. And so it is still a huge problem because of the already existing challenges within the healthcare system, and now compounded by this problem. But of course, some of these have been helpful, so that some of the issues around training of community members within the refugee camps helped, for example, to empower the refugees with knowledge and understanding about the disease and the preventive strategies that are being talked of. But of course, like I indicated, some of these very difficult to implement again because of the situation in which they are. And so that's basically the picture. Thank you, Prof.
Thank you, Victor. So we have about 7 minutes remaining in the session, and I think we have 3 questions. The first of which is to be posed by Richard, then Vincent, and then Kamantri. Richard, please go ahead with your question.
Thank you, Lulu. Can you hear me?
Yes, we can.
Okay, good. Anyway, I liked the last comment by Stuart, who said that they're literally losing patients, and that's true. We're literally losing patients all over the country because of they're largely unvaccinated, and the same goes for the United States. But this point on I thought there was no pun intended when he said they're losing patients, and I thought it was a nice one to use. But anyway, my comment or question is, isn't it true that the acquisition of the vaccine passport mitigates against spreading or acquiring the virus, and thus preventing poor clinical outcomes? And I think it's quite, for me, it's quite clear, and I'd just like to know the opinion of the panelists. Thanks.
Okay, Stuart, do you want to address this question around autonomy, individual autonomy and public health issues?
So Richard, was your idea, the use of these passports would have, benefits in terms of good clinical outcomes? Was that the question?
Well, the question is, I thought getting a vaccine passport will mitigate if you get the virus. It allows you to travel, but if you or free, let's say free movement, without causing or acquiring the virus, and if you do, the outcomes wouldn't be detrimental. Let's put it that way. So I would advocate for that, and I just wanted to know. I can't see any other reason. I understand that most people will not get a passport for other reasons, but as I said, it's different. It'll be different for different countries. But it's certainly shown that if you're vaccinated, if you get a vaccine passport, if you're vaccinated, you will mitigate against getting poor outcomes, clinical outcomes from acquiring the virus.
No, I mean, I think in principle, if you pass the criteria to get one of these passports, say you get an effective vaccine, no, leaving apart problems of duration and all of that. Yeah, it should be a case where your risk is lower of getting COVID-19 and your risk of spreading COVID-19 is lower. And, there's probably economic benefits and so on. I think most of the concerns about it are to do with equity rather than, does it have benefits? I think you could project that there would be benefits. I don't think you have to, because you're worried about the ethics of it, that you have to hide the idea that there are benefits attached to, this sort of approach. It's just, I think that a lot of the concerns mostly have to do with, well, not everybody can get these for one or another reason. To be able to travel, and so we end up with a kind of two-tier system. It's more that than whether there are these other benefits, because I think these other benefits are likely to be there, though they may be benefits that are, enjoyed by the few. That being, the central ethical issue for many.
I am in agreement with you.
Yeah, I think yeah, the benefits are not in doubt at all. We've seen, mortality rates coming down with the vaccinations, and we even know the spread is coming down. For those who watch the English Premier League, you see stadiums that are full with nobody masks and all that, because we know that the vaccines are really working. The other ethical issue that comes into play, and I've had these discussions before, is when people do not want the vaccine because they are afraid of the side effects. And so on the basis of potential harm, how do you force somebody to get something that has some potential harm? And then the issues of around emergency use authorization of the vaccine, the idea that no pharmaceutical company can be held liable for any harm that is caused by the vaccine. So these are some of the discussions that I've seen elsewhere. As to their merits or demerits, I'm not very sure, and it's debatable. Thank you.
Thank you, Walter. Vincent, can you go ahead with your question? Okay,
yes, I think Prof. Walter has touched on it, because currently our regulatory body, SAPRA, has released a statement to say that those that are suffering from adverse events from the vaccine can be compensated. Yeah, so currently, and the question would be, what will be the social dynamics with regards to the side effects?
So Vincent, can you elaborate a little on your last statement?
Okay, yes. I'm thinking about because with regards to vaccine hesitancy, I know that in some communities it's more to do with if I get vaccinated, then I get these side effects based on what they've seen from others that have been vaccinated as well. Those adverse events, and those that have been those also that have been reported, and then also the statement that came from SAPRA. It may have an effect on the vaccine intake as well. Well, whether people should trust taking vaccine or not.
So I think it boils down to the level of education that's provided in terms of side effects, how prevalent they would be, and for it really boils down to community engagement and education to allay people's fears. So Kumentri, I see your hand is up.
Thank you, Lulu. So Wayne, with respect to the question that you raised, I think it's absolutely critical to have continuing engagement with the public, education, counseling, etc. But do you know, we could continue like that forever and the pandemic will not come to an end. So we have a time constraint, I think, especially in South Africa, where we have adequate supplies of vaccines. The risk is that these vaccines could expire and that uptake is very variable at the moment. There are days when, the vaccine sites are full and other days when many sites are empty. So the waning uptake of vaccines is very concerning. We are only at 18% of, we vaccinated 18% of our adult population. So it's still far too little, for there to be any level of protection for our healthcare system, because we know our ICUs are full of unvaccinated people, our hospitals are full of unvaccinated people. And so what is happening in society is people, number one, some people are refusing to take a vaccine. They end up in hospital, they block a bed for those who may be vaccinated and need that bed due to breakthrough infections, but more importantly, they block that bed for non-COVID patients. And that is unfair. So, there's this concept of, can we sit and claim human rights, individual rights about the vaccine, and then go and impact on the rights of others within the healthcare system by depriving others of fair access to health, because we have an individual issue about a vaccine. So this is why there is justification for limiting individual rights in a pandemic. And, I think as Stuart has said, people's patience is running out, especially healthcare workers. We are having aspects like compassion fatigue developing, which never happened before within the healthcare profession. I mean, we've never had doctors and nurses say to patients, if you decline a vaccine, stay at home and look after yourself. We've never seen notices of where healthcare workers say, go ventilate yourself. This is the type of anger and intolerance that is developing within the profession. And it's really dangerous. We're on a slippery slope here if we are going to have a healthcare system with healthcare workers that no longer have compassion for people and for patients. So I think people in general are not fully appreciating the impact of their selfish actions to claim individual rights, and it's my body and I will decide what I put into it, etc. But when their health fails, they run to the healthcare system and expect the healthcare workers to take care of them. So it's this disconnect, between how people are interpreting rights and forgetting about responsibilities. It's that disconnect between individual, rights and public good. And it's such a big problem in South Africa because we have a very strong human rights culture and a very strong constitution. But there is so much misunderstanding around the culture of human rights and how we should and shouldn't be, applying it, especially during the pandemic. So I hope that clears up a few things. It's that it's great to do all this engagement, and it is being done, but there's a limit to how much time we can spend on that. And if we are not succeeding, we need to move ahead with mandates and more, measures that have been proven around the world to work better than incentives or just, nudging people along. I hope that helps a little bit. Thanks.
Thank you, Kumantri, and I think you summed it up quite well. So that although community engagement is a great idea, we don't have the luxury of having of being able to wait faced with the burden on the healthcare system and healthcare workers themselves, and also mandatory vaccination and and vaccine passports, although may work in some areas in Africa, it may not work in all of Africa because of access to vaccines. And then and as Stuart pointed out, that vaccine passports would work in developed countries, but would have may have some negative impact on low and middle income countries. So speakers, if you just want to sum up like in a few sentences, and then we can close the session. Whoever's ready can go.
Yeah, I think, this has been a very useful session, just to look at the ethics around public health emergency situations like what we have at the moment. And it's I don't have any additional comment. I think it's all been covered from my perspective. Thank you.
Thank you. Stuart?
Yeah, it's the last 18 months or so, I guess we're 19, 20 months, has been a kind of like a workshop, a global workshop for public health ethics. Everybody's starting to understand a little bit what public health ethics is about. And central to public health ethics is trying to do something like infection control in a way which is harmonious with our other values, the other things that we find important. But sometimes that it just is very hard. It's very hard to do. And I think that that's becoming increasingly obvious with this global pandemic, is that while certain kinds of respectful approaches, very respectful approaches to people's individual choices is ideal if you can do it, I think that is becoming increasingly difficult to maintain. And I think that's what we're seeing increasingly over time, is that the balance has been shifting. And now is shifting a little bit more towards the imperative of infection control, because we are not controlling it very well.
Thank you, Stuart. Victor, you have the last word.
Thank you so much for the opportunity. And so for Zambia, we are still far. In fact, for the vaccine issues, like I indicated, we are just around 900,000 out of 8.7 million expected. And so a lot of lessons learned, discussing issues that we are yet to confront, but some of the things already have been observed. Vaccine hesitancy has been there, even with just the initial 280,000 doses we got. We found problems with just the frontline workers going forward to get this, but and so it was opened up to public to just encourage exhausting this before it expires. And so the same issue that Prof. Modley talked about. And so there is this limitation in time and all, but then, now we get to see that that was only promoted, the uptake was only promoted when we got into the third wave and people started dying a lot. And then we see more people coming forward to getting the vaccine in July, August. And so a lot of lessons that I've picked up here, ethical dilemmas and a lot of practical, again, considerations that have been highlighted, learning from Prof. Stewart and also Prof. Modley, and the other speakers who chipped in with comments. And so even to the consideration on mandatory vaccinations, it's a huge issue to really reflect on. And so I've picked on quite a lot. And so thanks a lot to all. Thank you.
So it remains for me to say thank you to our three speakers for their excellent talks and for provoking some insightful comments from the audience. And to the delegates, thank you for being engaged, and we look forward to seeing you for the third plenary session tomorrow, which is on regulatory and guideline updates. Thank you, everyone. Have a good evening and goodbye.
Bye-bye all. Thank you.